Hello guys, welcome back to the channel. It's Unit-8 Part D. Prolonged labor. This labor takes more time than the normal labor takes. For example, if you see generally a normal delivery should occur within 18 hours. That is, if a woman gets now her labor pain, within next 18 hours she should give birth to that baby. If it is taking more than 18 hours, then automatically it's a prolonged labor. But to find whether the labor is going to be prolonged or not, we will not wait for 18 hours. Like, let's wait for 18 hours. If the baby is not born, we will consider it as a prolonged labor. We will not do that. In the middle, the process, by seeing the progress of the labor, we will get to know whether the labor is prolonged or not. Like cervical dilation, the opening of the cervix, the opening of the vaginal opening, we will get to know whether the labor is normal or prolonged one. Within 1 hour, at least it should open 1 centimeter. And next is descent. Throughout the delivery process, the baby will be moving out. Baby will be trying to come out. And while baby is trying to come out, automatically the cervix dilation will occur, and the baby's head will start to be visible in the vaginal area. That also should be 1 centimeter. Based on this cervical dilation and descent, we will get to know whether the delivery is normal or prolonged labor. How prolonged labor occurs is generally based on these three things. First is power. Based on the woman's power, she should apply force at the time of delivery. Even based on that thing, the delivery process will be affected. If there is any problem in push technique, and if the woman has been given sedative or analgesic, because of that also the women will not have enough power to do push, so maybe that also affects the delivery process. And if you see the passage, that is the pelvic region, if the pelvic has any problem like CPD, android pelvic, and if any pelvic defect or any tumor present in that, or any injury or scars, like if previous delivery has undergone c-section, there will be a scars in that places, even that also affects the delivery and leads to prolonged labor. And next, the passenger, that is the baby. If the baby is too big, it can't come out, or if the baby is in the mal position, mal presentation, even at that condition normal delivery will take time. Apart from this, if the baby has any abnormalities like congenital abnormalities, that also leads to prolonged labor. And next, based on the duration, we can find whether the labor is undergoing normal delivery or prolonged delivery. Like if the woman's delivery, this is first time, this is her first delivery, that is premigravida, then the first stage should occur within 12 hours. That is, for example, at 1 o'clock, the woman got her labor pain. Within next 12 hours, the first stage should get completed. That is, the crowning should be done. The baby's head should be visible within next 12 hours. And after 12 hours, within next 2 hours, the baby should be born. This is in the premigravida, the first delivery. In second or third delivery, that is in multigravida, the count is different. In multigravida, the first stage should occur within 8 hours. For example, at 1 o'clock, if the woman has got her pain, within next 8 hours, the crowning should occur. The first stage should get completed. And after that, within 1 hour, the baby should be born in the multigravida. Management of prolonged labor, the very first thing we do is we try to prevent it. If prevention is not possible, the labor has started and it is a prolonged labor, then we will try to find the cause, what is causing the prolonged labor. After finding it, we will try to protect the mother and fetus from getting injured because of that cause. Prevention of prolonged labor, it is generally done in the routine checkups. At the routine checkups, while the scanning times, we will get to know whether the baby is growing correctly or not, or baby is comparatively big than the normal required level. We will get to know the baby is in big size or baby is in the mal position. Like that, a few things we'll get to know, which is an indication for prolonged labor. Apart from this, at the time of delivery, at the beginning, they'll perform a patography. By that, we will get to know the baby's position and presentations. At the time of delivery, to induce delivery, we will administrate oxytocin. If oxytocin is administered too much, then automatically there will be a rupture of membrane. Because of extra contraction and relaxation, there will be a rupture of membrane. If there is a damage in the passage or the muscle, then automatically the normal delivery takes some time. It leads to prolonged labor. Then after that, we will try to find the cause. Based on the cause, the process of the delivery will be detected. For example, if the cause is very small, like there is a scar, okay, or if there is any, if the mother is dehydrated, in that conditions normal delivery is quite possible. We will try to perform the normal delivery. If, for example, the pelvic is not in the correct position, like CPD or malpositions of babies in the malposition, malpresentation, then the normal delivery cannot be performed. We will go with C sections. When we are performing normal delivery, at that time there is a chance of using forceps delivery. Forceps delivery might occur. At that time, there is a chance that baby's head might get injured, and there is a risk of infection and risk of injury will get increased. We need to take care of that, and mother might get dehydrated for that fluid, and if there is any pain is seen more in the mother, for that analgesic. And after the delivery of the baby, we will detect the blood level of the mother, and if there is lot of blood is lost, then automatically we will provide blood to the mother, and other things based on the requirement of the mother will be provided. These are the managements of prolonged labor. Shoulder dystocia. In this condition, if you see, it's an obstetrical condition, which means it's a problem to a delivery. In this condition, either one or both the shoulders during the delivery period, the baby's shoulder gets struck and the baby's outcome will not be possible. The normal delivery will be a critical condition. It can be either the baby is large or even the mother's pelvic can be small. Either the condition, the shoulder dystocia is seen. Risk factors of shoulder dystonia. In the history section, if you see, if there is a previous history of shoulder dystonia, then absolutely this time there is a chance that shoulder dystonia may occur if the cause was related to mother. If mother has any underlying disease condition like diabetes, hypertension, that also leads to this condition, and mother has obesity, then definitely that to lead. Antepartum factor is nothing but during the pregnancy when the baby is growing. At that time, if baby is growing too much, that is a macrosomia, big baby size, that can lead to shoulder dystocia. If mother has any underlying condition and overweight gain, definitely. Apart from this, during the delivery time, that is intrapartum factor, we will get to know the pelvic condition. If CPD is present, then normal delivery is not possible. If there is any problem in dilation, that is opening, or if there is any problem related to descent, that is movement, the baby is trying to come out and the baby can't, baby has been failed to come out. If there is a problem in descent and dilation, then definitely this also a risk factor that is related to shoulder dystocia. Management of shoulder dystocia. Okay, if you see, before the delivery is progressing, the baby is not able to get into the pelvic. This is pelvic. The baby is not able to get in because the pelvic is very small. At that time, we will just stop it and we will perform C-section. But just imagine the baby has passed almost midway of the pelvic. The baby's head is visible. The baby's shoulder is struck now. We can't push the baby inside and then perform again. C-section is not possible. At this time, how we are going to manage it? First, we need to stop these three things. That is, we need to stop this push technique because it may cause, may not, actually it causes injury to the mother and the baby. And pull technique is also stopped. And pivoting is nothing but trying to rotate the baby, trying to change the position of the baby by rotating. That also causes injury. We need to stop these three things. We will try to perform episiotomy, that is cut between anal and the that perineal area. Episiotomy will be performed, and after cutting, the doctor will perform Ruben 2 technique. This technique is, he will insert his finger and he will catch the posterior shoulder, either the shoulder arms, and other hand will be in the base. It will be giving the push power. By applying push, the doctor tries to remove one hand and make sure the baby is very delicate. You can't injure the baby's shoulder line. It should be performed in a very delicate manner. One hand, the posterior arm will be delivered, and next the other arm, automatically the normal delivery will be performed. This is the management of shoulder dystocia. Questions will be provided at the end of the chapter. Until then, stay tuned. Bye.